Hello and welcome to APP to APP virtual lectures. We have two viewer audiences for us tonight, APP to APP and My Catholic Doctor. My name is Amanda Michaud. I'm a PA in Allergy and Clinical Immunology in Jacksonville, Florida, here to talk to you all tonight about atopic dermatitis, also known as eczema. Let's get started. Okay, so first let's talk about a little bit of prevalence. Eczema or atopic dermatitis affects 11 to 25% of children. Typically, this is very early onset between the ages of 3 to 6 months, with 90% of those presenting by age 5. But it is a common misconception that it's only a pediatric illness. We do see adult onset atopic dermatitis affecting 10% of the adult population, with about a quarter of those adults actually being adult onset patients. They do present with kind of various phenotypes, sometimes not with the typical history, but this is a recognized condition that we'll see first present in adults as well. And we do see atopic dermatitis being more common in Black, Asian, Hispanic individuals, non-white individuals as well. When we think of the atopic march, a lot of us have seen this at some point in our training before. This is the progression and development of the typical allergic diseases along the timeline of a patient's development and growth. So we'll typically see on the left side of your screen here, we'll typically see atopic dermatitis and food allergy early on in life, usually by age 1 and around that area. And then other allergic diseases like allergic rhinitis and allergic asthma later on in life, which allergic rhinitis will typically start to really show up with more severe symptoms around early school age. Looking at another way to kind of look at that atopic march, this is another kind of diagram on the right side here. This shows kind of different temporal factors that can be related to the development of allergic conditions. So we'll have various genetic predisposition factors or environmental factors that can lead to patients developing persistent atopic dermatitis, a continual impaired skin barrier, allowing allergen penetration, activation of Th2 cytokines, and sensitization, and then continued exacerbations of that atopic dermatitis over time, and then later on in life, perhaps development of food allergy, asthma, and allergic rhinitis. It is a common misconception that food allergies cause eczema. Usually it's the eczema and the impaired skin barrier and the sensitization of food allergens through the skin that actually causes food allergy. So it's important to make that differentiation as well. Looking a little bit deeper in the pathogenesis of AD, there are two major theories about what is actually going on. And that is related to the two major things that's going on in atopic dermatitis, and that is barrier dysfunction and cutaneous inflammation, or also called immune dysregulation. So we have two major theories, inside out or outside in. Inside out refers to that internal pro-inflammatory environment with activation of various Th2 cytokines that promote inflammation or immune dysregulation that then causes the barrier dysfunction. Whereas inside out basically refers to the fact that a barrier problem causes that internal activation and inflammation. The real answer, the verdict is still out. The real answer is we think it's a combination of both of these, and it really depends on the person and the patient and their age of presentation and other cofactors. A lot of research is done in this area these days to help identify the underlying phenotype or endotype to these patients. Now, diving in much more detail, we'll make this really brief because this is a very busy slide. When we look at the first onset of AD over on the left, when we have non-lesional AD and that disrupted barrier, filaggrin, loricrin, involucrin, and decreased lipids that we notice at the top here, filaggrin, loricrin, and involucrin are proteins that help keep the skin barrier intact. Imagine the mortar that keeps the skin cells together, basically supporting an intact skin barrier environment and protecting the internal environment and allowing good things to stay in and bad things to stay out. And then we have this disrupted barrier that allergens and irritants and viruses and different things, chemicals, temperature changes, everything can kind of come in and activate Th2 or various cytokines. When we're in the acute stage, we see a lot of activation of various cytokines and inflammatory processes. And all of these processes basically recruit more immune cells to come to the site, which leads to this ongoing constant itch scratch cycle. And then in chronic AD, we see more of a development to Th2 allergy or rather Th2 inflammation, and more lichenification or that thickened hyperlinearity we'll see with atopic dermatitis. So depending on the stage of the atopic dermatitis, we'll see various inflammatory molecules and pathways involved. And so a lot of our research and more targeted therapies relies on targeting some of these, and we'll talk about that towards the end. So when we think of other things that can coexist with atopic dermatitis or comorbidities of AD, we of course think of those other allergic or atopic conditions. We also know that AD can be associated with various immune-related conditions like immune deficiency, skin infections. Patients with AD most commonly are carriers of staph on the surface of the skin, which can drive this inflammation even further, and they'll be more prone to various skin infections, not only staph, but also viral skin infections like molluscum and herpes infections as well. We know that there's a significant burden of AD on our patients from a mental health perspective, both in patients and caregivers of younger patients with AD. We see an increased issue with bone health, especially in patients that are perhaps not appropriately managed and routinely given systemic or oral corticosteroids. And then there's also some research that suggests that the presence of atopic dermatitis puts patients at increased risk of cardiovascular and metabolic diseases. Another graphic to kind of look at this is from the National Eczema Association website, and I really wanted to include this because it just is another way to look at all the different things that can coexist with AD. Of course, asthma, hay fever, allergic rhinitis as well, food allergy, infections like we talked about, significant sleep disturbances. We can see an increased rate of alopecia, cardiovascular disease like I mentioned, and then mood disorders like depression, anxiety, to the point of course, patients feeling suicidal because of the severity of their skin. Another thing worth pointing out is that about half of patients with persistent atopic dermatitis actually have allergic contact dermatitis as well. So they're adding fuel to the fire by using topical agents, cleansers, soaps, and even some of their topical medications that may contain a preservative or a fragrance or something that they are actually allergic to and they have become sensitized to. So it's important to understand that all of these things can go on together, and many of our patients in the allergy clinic have majority of these conditions in addition to their AD. When we look at the diagnostic criteria for AD, there are a lot of different protocols and kind of algorithms that we can use to properly diagnose AD, but ultimately it is a clinical diagnosis. A biopsy can be helpful to rule out other conditions, especially in adult onset AD, but a biopsy does tell us nothing about what type of eczema that is. A biopsy might say that there's spongiotic dermatitis with some eosinophilic infiltration, but that does not differentiate between contact dermatitis, atopic dermatitis, infestations or arthropod bites, or other types of conditions that can cause an infiltration of eosinophils. So we cannot rely on biopsy alone, but when we have a suspicious case, a biopsy can be helpful to support our diagnosis or rule out others. So when we look at the clinical criteria that patients have to have AD, the two major things is that we have to have pruritus. AD is always itchy. And in fact, itch is like usually the #1 complaint in these patients. A lot of them, if their skin lesions were clear, they wouldn't care as long as their itch is controlled. So itch is a huge part of AD, and that's what causes a lot of the mental health burden of AD. And then we'll also see the classic eczematous lesions with a chronic and relapsing course. And what that means is that it just comes and goes over time. And patients will often wonder, what did I get into? What flared this? It's nothing necessarily that they're doing. It's just the natural course of AD is this kind of chronic, ongoing, chronic, relapsing, remitting course. It will come and go and get better and then get worse on its own. And then we'll see the typical morphology. These lesions will look excoriated. They'll have lichenification on chronic lesions, papulation, erythema, of course. We'll talk a little bit about that. I'll show you some pictures in a little bit. And then most patients with eczema will have some type of age-specific pattern or presentation. Other important features that add to that support of diagnosis is, of course, having early onset. It is more likely to be AD, having a personal or significant family history of other atopic conditions, and then just overall xerosis or dry skin. A lot of these patients will tell us that no matter what they do, no matter how much moisturizer or lotion they put on, their skin just still feels really dry and like sandpaper. There are several other associated conditions that don't really add to the essential criteria to diagnose AD, but we'll see things like keratosis pilaris, pityriasis alba, which is that hypopigmented skin, that can go along with that, as well as more increased susceptibility to skin infections and other things listed here. But the main criteria, the most important essential criteria, are listed on the left here. Going back to our differential diagnosis and how sometimes a skin biopsy can be especially helpful to rule out some conditions, specifically a skin biopsy can be helpful when AD can often sometimes look like tinea, especially in the early stages. It can also look like psoriasis or psoriatic lesions, especially when patients are lacking those classic silvery scales that we'll see in more advanced disease. And then, of course, some of the big things that we think about with our patients that are older and adult onset that have more well-demarcated lesions, we want to make sure that they do not have cutaneous T-cell lymphoma. That's really important not to miss. And that's one of the big reasons why we may send an adult onset patient to the dermatologist for a biopsy. But a lot of these conditions listed here will show up the same on biopsy. But these are all the things that are going through our mind when we are seeing a patient with AD, especially adult onset. We got to rule out these other things and make sure what we're dealing with is truly atopic dermatitis. So looking at the various presentations, AD can show up in typical kind of morphology and distribution patterns based on the age of the patient. We'll talk about that pretty soon, but we'll see classic signs like in infants, for example. They'll primarily have it on their face and their cheeks, and this little guy here, on the creases on the back of the knees, the popliteal fossa, and on the neck, or I'm sorry, and on the back as well, as shown here in this on the bottom here. We'll see pityriasis alba, especially in patients with more skin pigment. That's the hypopigmentation here associated with AD. Those Denny Morgan lines that was listed on the previous slide, that's these hyper accentuated lines beneath the eyes. That's what Denny Morgan lines refers to. Hyperlinearity is also seen on the palm on the top left here. And then overall, just the significant excoriation, erythema, scabbing, oozing, crusting, papulation. This arm here, I believe that this picture shows a lot of chronic lichenification, that thickened skin, those accentuated skin lines. These are all various presentations of how we can see atopic dermatitis show up. So looking at those typical distribution patterns, these are some patterns that we'll often see in our AD patients. In babies, especially infants and to maybe little toddlers, we'll see scalp and cheeks and their abdomen and their back, and usually the front of their body involved in their lower extremity. In young children, up to probably right before adolescence, we'll see that kind of progress to involve more of the antecubital fossae bilaterally, the wrists areas, as well as the ankle joints and popliteal fossae. And then we'll also see a various presentation in adults. They might actually continue to have the antecubital fossa and popliteal fossa involved, but we'll also see more facial dermatitis as well as hand and foot dermatitis. We talked a little bit about the burden of disease, and I really just want to highlight this a lot more. There's a significant impact of quality of life based on atopic dermatitis, and we know that patients with atopic dermatitis have a significant disease burden from a mental health perspective as other chronic diseases, on par with diabetes, for example. So significant issues affecting quality of life. These patients will have significant social impairment because of their symptoms, how they're feeling, but then also their visible skin lesions, increased depression, anxiety, other conduct disorders or ADHD, especially in young children. And there's a significant caregiver burden, especially if that caregiver is the one doing the skincare for the patient. We also have numerous objective and subjective scoring indices. We'll talk about a little bit of the objective scoring indices in a little bit when we talk about the medications that are out there for AD and how effective they are. We've got the IGA index. We've got the SCORAD, the EASY. They all do it a little bit of a different way. I'm not going to go into details on the finer points of these scales, but they're all ways that we can objectively use an assessment, a clinical decision tool to really guide us in understanding how severe that patient's disease is. Then we also have numerous patient-reported subjective scoring systems as well. There are some for patients, some for children, some for their adult caregivers, but those would include things like the PP-NRS, which looks at the peak pruritus score, it's how itchy they are, and then overall just their experience with their AD day to day. So these aren't always things that we have time to do in clinical practice, but I always try to sprinkle my clinical history with some of these questions and normalize the idea that we understand a lot of these patients are anxious and depressed. And I want to normalize that conversation and hopefully open up that door for conversation, and have my patients be more comfortable sharing that with me. So something that's important to understand with AD. So let's get into treatment. So we have multiple steps and many, many things we can do for AD. In the last 10 years, this area of medicine has seen a huge explosion of research and different therapeutics that we can use, and lots of research on our older therapeutics. So all of atopic dermatitis patients, we want to make sure we're doing basic management for all those patients, and that's all AD severities. We want to make sure we're avoiding their triggers if we know that they have some type of triggers, usually aeroallergens, for example, pet danders, whatnot. We want to make sure that they're getting a daily bath or shower with appropriate skincare. We'll talk about that. And that they're liberally using and frequently using moisturizers or emollients. In mild AD, those that have just a little bit of flare up every now and then that are really mild, we want to use our kind of classic tried and true topical corticosteroid, low to medium potency, but we also have some other options that we'll discuss as well. And then with mild to moderate AD that has more frequent exacerbations, we want to consider proactive over reactive therapy. So we'll talk more about that. And then finally, when they're falling in that moderate to severe category, that's when they really need to see the specialist. And I would even argue seeing us earlier, especially if they have other atopic comorbidities. But we really want to think about more specific therapy to treat that patient's eczema, more targeted treatments. There's so much we can do now, and many patients and providers don't even know that these agents exist, more than just the typical immune modulators or immune suppressive therapies or steroids that we use forever for these conditions. And we'll talk a lot about all of these therapies as well. So looking at the basic management, so that refers to regular bathing, application and frequent use of moisturizer, and trigger avoidance. So bathing, we want that to be daily in warm water. Just bathing alone without the presence of soap at all or any cleanser has been shown to decrease skin bacteria and other irritants on the skin alone without any additional treatment. That in itself can substantially decrease AD severity. Moisturizers can improve barrier function, increase hydration, and decrease something called transepidermal water loss. So what that refers to, and this is a big part of eczema research when we look at how effective eczema treatments are on a cellular and molecular level. Transepidermal water loss refers to the water molecules that are cohesive and stick together and can reach through that impaired skin barrier and pull some of the moisture from the skin with them as that water evaporates from a patient's skin. So transepidermal water loss is a big measurement that we look at for AD severity in more scientific research studies. We know that moisturizer can prevent that, and we'll talk about tips and tricks of how to apply moisturizer appropriately. Just application of moisturizer and bathing in the right way can actually improve symptoms significantly, like I just mentioned. And then trigger avoidance. We want to avoid the known aeroallergens. We want to limit irritant exposure. So that's things like avoiding the use of fragrance and other preservatives that we know can be very irritating to the skin. All of these patients tend to have really sensitive skin and break out often. So it's important to try to eliminate those extra things that can exacerbate the disease as well. And then we also know that temperature changes and humidity changes can play a role as well, with everyone sort of having different triggers there. Looking at moisturizers, there are a variety of formulations. We've got lotions, we've got creams, ointments, and gels. They all contain a different percentage or proportion of water, emollients, and humectants and different things in there. Like we mentioned on the previous slide, they're effective at increasing skin hydration, reducing AD severity, and reducing the need for prescription therapy. And I will tell you, nothing gets a parent of a toddler with severe AD to buy in more than you telling them that they don't need to use their topical prescription steroids as much, because if they're doing proper skincare, they may not need to. So that's a pretty big deal to us when we talk about education on skincare. Moisturizers can also be used as a preventative way to prevent flares once a flare has been controlled. And a big Cochrane meta-analysis did show all of this benefit. So efficacy and safety at reducing severity, preventing exacerbations, and whatnot. So this has been studied pretty intensely, just looking at moisturizers as well. I like to refer patients to the NEA product directory, so I wanted to share that here. This is the National Eczema Association, which is a nonprofit regarding eczema education. They do a lot for eczema patients, and they have this awesome product directory or database where you can go in and find what you're looking for: sunscreen, moisturizer, shampoo, conditioner, and it gives you different products that have their seal of acceptance, that are known to be gentle and formulated with the sensitive skin patient or the AD patient in mind. So whenever I have patients call our office or ask me, I don't know what to use, and especially with sunscreen, I'm in sunny Florida, so that's a big part of my eczema patients every single day. We always refer them to this website, and it can be super useful. Other non-pharmacological interventions include frequent bathing. And there was a time, and I guess this still is something we hear from time to time, that patients are being told to bathe less frequently. And then some patients are being told, especially by us, to bathe more frequently. And the question is, well, what actually works? And the answer is more frequent bathing, if you are doing proper skincare afterwards, is preferred. If you don't have time to do proper skincare, then you want to skip the bath. So we also know that better bathing and moisturization practices will be helpful. So really the right answer is that more frequent bathing is helpful, but you have to do the skincare. And it's a lot for some of these patients. So what we recommend is something called soak and seal. And we'll talk about this in a little bit. I'll have a graphic up on the slide. Soak and seal is when we have a 10-15 minute shower or bath, and we apply moisturizer right after the bath, basically when the skin is still damp, to lock in that extra moisture and help to seal that within the barrier to help prevent that transepidermal water loss and increase skin hydration that way. We also want to make sure with bathing that we're using limited use of non-soap cleansers, making sure that we're using fragrance-free and hypoallergenic product. Something that says unscented is not enough. It has to say fragrance-free. Something that says it's unscented has no perceivable scent that we can actually smell and interpret through our sense of smell. But there could actually still be fragrance in there, masking other fragrances that perhaps we don't smell, but when we apply it to our skin, it can cause a severity in dermatitis or a significant flare. So important to keep that in mind. Fragrance-free is a way to go. Wet wrap therapy can be utilized with or without topical steroids. We'll talk about that in a little bit. And adding things to the bath water outside of bleach baths, which we'll talk about in a little bit as well, like oils, essential oils, other emollients to the bath water, has not shown to be effective. So emollients refer to those topical agents that have really high lipid ratios to improve skin barrier function. And they can be applied multiple times a day. They're technically not medicine, even though there are prescription grade emollients that are out there. There's overall minimal research on their efficacy, but one randomized head-to-head study with a small group of patients actually showed that petroleum jelly does the exact same thing while being over 47 times less expensive. So yes, petroleum jelly or Vaseline, like shown here, is very thick and takes a while to dry, but that can be actually better or equally efficacious to these prescription emollients like Episerum and things like that. Now, those other prescription-based emollients that have that higher lipid concentration, a lot of times we can't always get good coverage for that. We have to use special mail order pharmacies. It can be kind of a pain in the butt, but a lot of patients do like the texture and the thinness of those products. So I always offer that to patients, but I do let them know that Vaseline is usually just as effective, but much more cost-effective. Back to what we talked about with soak and seal, or what we call soak and smear as well. This is a way to bathe properly, like I mentioned, to improve the skin barrier function and also the benefit of topical treatments, especially topical corticosteroids. And it can be really helpful when skin is especially really flared or inflamed. So basically, the idea is you fill the bathtub up with water, or of course a shower if it's an older child or adolescent or adult, and they soak in the tub with or without soap or in the shower for 5 to 10 minutes. Then after bathing, they pat dry with a towel, leaving it damp, apply the prescription topical medicine to all the hot spots, and then moisturizer everywhere else after a few minutes to help seal in that moisture. That's why it's called soak and seal. I will often give patients resources on this and refer them to some really good websites that show videos of how to do this properly. Okay, and looking at wet wrap therapy, this is a more advanced way to do soak and seal where it takes it a step further. You do the bathing like we mentioned on the previous slide. You add the topical medications when the skin is still damp, or moisturizer if you're just doing moisturizer, and then you add some type of dressing. So this can be some type of gauze roll. It can be some other type of cotton dressing. We've even had patients that have leg and arm dermatitis that will take a tube sock, like an adult-sized tube sock, cut off the foot part, dip that in water, and put that onto the arm as a sleeve or a band to try to cover that AD, especially knowing the common areas on the arms and legs. And depending on the size of the patient, that works really well. We've also seen that there are specific AD garments that are sold. One company is AD Rescue Wear. They're quite expensive, of course, but they just target that area that you're really trying to treat really well and can be a lot more convenient for parents. You can also just use regular fitted cotton clothing, like a fitted cotton long sleeve t-shirt or leggings as well. And then on the face for babies with severe eczema, we'll recommend doing gauze wraps, kind of like a little mummy. And I have some pictures, I think, on the next slide here. So this is what they do in a lot of the AD research centers that have inpatient units where patients present with pretty severe disease and they get admitted to the hospital to do wet wrap therapy and treat them appropriately before sending them home. And these examples are this little baby here covered in AD. She has pretty widespread disease. They wrap her up like a little mummy with various wraps and coverings on different areas of her skin. And then literally a day or two later, her skin looks like this. So we're talking pretty profound improvement. Here's another example of a patient, what looks like an adult or at least an older adolescent child with severe eczema on the legs following wet wrap therapy. And then my favorite, this little guy on the right, covered in AD, looks like a burn victim, right? I mean, this is pretty severe advanced disease. And these parents, by the time they come to you, they are absolutely desperate and they need help. They are willing to do anything. And sometimes it's just educating on the proper skincare and doing wet wrap therapy with what they already have. Many times these patients our parents are so frustrated and desperate, they'll often leave our appointment sometimes, and I anticipate this, that they'll leave the appointment disappointed that maybe we didn't add more therapy or try different treatments yet, but then they'll go home and do this, and I get them to buy into doing the wet wrap therapy for a few nights, and we see this substantial improvement. And then once we see this improvement, it's much easier to maintain with a proactive treatment approach. So great results there. Now, topical corticosteroids. Many patients are familiar with using topical corticosteroids to treat their AD. A lot of us providers from various specialties have used topical corticosteroids for numerous other skin conditions, but they really are first line and the mainstay treatment for atopic dermatitis and can have significant improvements in both acute and chronic lesions. In general, we recommend twice daily, but a lot of more recent research tells us that once daily might be enough for some patients. But then during significant flares, we can go from that low to mid potency topical steroid to a higher potency topical steroid. But we need to reduce that potency when we're treating sensitive skin sites. So like the face, neck, axilla region, or the groin, there is a higher rate of systemic absorption there, and we're much more likely to see side effects like skin hypopigmentation secondary to the steroids if we use a steroid that's too strong. In general, I like to avoid using steroids in those sensitive skin areas, but in some cases we can use a very, very low potency. So let's talk about that potency. This is not an exhaustive list here on the left, but this goes through some examples. So the most common one that we really see prescribed and that a lot of us kind of watching this video probably have used numerous times is triamcinolone acetonide cream or ointment, 0.1%. That's a good place to start because it's medium potency. And really with the right skincare and the right education of how to apply topical steroids or topical treatments, we don't have a lot of patients that need to go above medium potency steroids. So that's always helpful to know. That absorption and potency really depends on the vehicle that the medication is used in. So whether that's an ointment, cream, gel, or spray. Ointments are the best, but a lot of patients don't love to use ointments. And we know that if they don't like to use what we're prescribing to them, there are times that we can reason with them, of course, but if they don't like to use an ointment and they tell you they don't want to use an ointment, you really should work with them and give them a cream instead. And you might need to go up to a higher potency, but we want to make sure that they're using something and have something that they're actually going to use. And that applies to good moisturizers as well. Less occlusive agents like creams and lotions, however, could have more sensitizing agents for atopic dermatitis within them. We can see this as a preservative, let's say, or a surfactant, something that makes it more kind of easy to spread and thinner. Those are often some of the biggest causes of allergic contact dermatitis, where a patient is exposed to that through that faulty skin barrier and develops an allergic reaction to that product. And sometimes with topical steroids, we'll kind of see this pattern emerge where they're getting some improvement from the topical steroid, but they're actually allergic to something within the agent. So they're just not getting better. They're reacting to a preservative in the cream while the steroid's still trying to fight the inflammation, and they're just not getting improvement. So when I see that and a patient's doing really good skincare, it's nice to kind of change it up and giving them a different class of steroid that they may tolerate better. And like I mentioned, patient preference is important, and sometimes we'll have to deal with coverage issues as well to get a patient on the right one. So we'll get a lot of questions about how much to use. And of course, there's a lot of steroid phobia, and sometimes we'll find out that patients are not using nearly enough. So this is a really good graph. This is also from the National Eczema Association website that goes over, based on the age of the patient and the location of the AD, how many fingertip units from the first joint to the fingertip, how many fingertip units of how much steroid you should use. So for example, if I have a 4-year-old who has leg and foot dermatitis, they're going to need 3 fingertip units of topical corticosteroid to adequately cover that area, most likely, unless they're abnormally large for their age, perhaps. So looking at adults and 10 years through adult at the bottom here, for the same area, they need 8 fingertip units. So that's a lot more, right? So it's important to tell your patients that they can use more of this if they're not spreading that area. A lot of patients are afraid, but we're not going to get the proper effect of the topical treatment if they're not using enough. Proactive therapy is something we do a lot. So in those medium severity patients that might waver sometimes between mild disease and moderate disease, we do a lot of proactive therapy rather than reactive. So what this looks like is they treat their exacerbation. They use their topical steroid for however long they need to. Another common myth and misconception that we hear a lot of is that patients are told that they can only use a topical steroid for 14 days or 21 days at a time. There's no magical thing that happens at 14 or 21 days. And the most frustrating part of them being told this bad advice is that if they're getting better and they're almost clear and they suddenly stop because they're afraid something awful is going to happen if they continue for day 15, then the eczema gets bad and relapses again. So we really want to focus on getting their skin clear, and that might take 2 to 3 weeks or more of consistent therapy. Now, it's different if they're not improving at all. So if they've been using a topical steroid for 2-3 weeks and they're not getting any change in symptoms, then we need to reassess and change to a different agent or kind of think about what else could be going on with this patient. But if they're improving, it's okay to continue beyond that 14 to 21 day window. So proactive therapy refers to that patient that was using twice daily treatment, whatever that might be, topical steroids, let's say in this case. They're clear. They continue the topical for 1 more day because, as we know from that diagram I showed early on, eczema lives just underneath the surface of the skin and is ready to ramp back up any moment. They continue for that 1 more day, and then they slowly taper down. So instead of twice a day, they go to once a day, then every other day, then every 2 days, with the idea that they will eventually stay using their topical mid-potency or low-potency topical steroid once to twice to 3 times per week max on the typical eczema-prone area. So the one thing about eczema that does differentiate it from other types of allergic diseases, like chronic hives, let's say, we will see it affect usually the same areas over and over and over again. And the patients know that. Some people do have widespread disease, but some people only have specific areas. So they'll put the topical steroid only on the typical eczema-prone areas, even when they're clear, as a way to prevent an exacerbation. Study has shown this is safe without significant adverse effects. There was a huge systematic review done in 2022 by a Cochrane database that showed how safe and effective this is for long-term use. And they followed patients out for several years, showing that this is an effective way to not only prevent exacerbations, but also to reduce topical steroid use long-term by doing proactive treatment. Another thing that you can really sell to parents is if they know that doing something proactively will reduce how much their child has to use a topical steroid long-term, treating those flare-ups instead by controlling them in the first place, they're going to be on board with this therapy. It's important to address the known adverse effects with topical steroids. Like I mentioned, they're typically related to the location applied and the potency, but it is important to address steroid phobia. You have to understand these patients are going to go home and be worried about using a topical steroid, and many patients do prefer to use a non-steroid. And even though topical corticosteroids are considered first line, if a patient and a family member, parent decides they want to use a non-steroidal first, I'll acknowledge that that's a reasonable approach. They may improve, but then we'll know that this is our backup plan if they don't. So it's important to discuss that a lot of these side effects are related to long-term use and significant potency, but also the side effects listed in the package insert are from oral steroids, right? So we need to make sure we're having these discussions with them ahead of time. The more common things that we worry about are the skin atrophy or that hypopigmentation from chronic ongoing use, as well as poor wound healing, especially if it's applied at the site of an infection or a wound, and then that localized cutaneous immune suppression that can make them at increased risk for other skin diseases like viral infections, for example. This is a summary of a huge analysis that was done looking at long-term safety of low and medium potency topical steroids. Does not increase the risk of skin thinning, does not increase the risk of growth abnormalities or adrenal insufficiency or lymphomas or non-lymphoma cancers, and does not increase the rate of skin infections or impair the response to vaccines. And I like to talk about this data as well, because a lot of the scary side effects are associated with really strong topical steroids or oral steroids. Next, we'll move on to some lesser known agents that are widely used in specialty clinic. This next category are the topical calcineurin inhibitors. These are non-steroidal immune modulators that inhibit cytokine production by inhibiting calcineurin. So in oral form, these are used for transplant rejection or preventing transplant rejection. But in topical form, they're used for AD and other skin diseases. They are considered second-line therapy to be used in patients where topical treatments otherwise haven't worked for them. So let's say other topical steroids. It's approved for ages 2 and up, but we see efficacy and safety in younger ages, but we just really can't get it for those younger age groups. We have pimecrolimus cream and tacrolimus ointment in 2 strengths. In general, we know that safety has demonstrated, some studies have shown that we can use this up to 6 weeks if needed, and really for non-continuous use to kind of treat exacerbations. I really like to use TCIs or topical calcineurin inhibitors on the face, and I like to use it for my maintenance proactive regimen. Looking at effectiveness, like we talked about, ointments like tacrolimus tend to be more effective than creams like pimecrolimus. A lot of people really like the pleasing kind of consistency of pimecrolimus, but unfortunately tacrolimus is usually the preferred agent on most payer plans, so we use that more frequently. So the ointment is obviously stronger than the cream here. A meta-analysis actually showed that tacrolimus 0.1% is as effective or just slightly less effective than a mid-potency topical steroid. And that's important to note because we're starting most of these patients on a medium potency. By the time they're referred to our office with uncontrolled AD, they're already on, let's say, triamcinolone, which is medium potency. So this has similar effectiveness without being the steroid. So something to point out. The most common side effect that we see is stinging and burning. And unfortunately, up to a quarter of patients will experience that. It's one of the reasons why people won't like to continue using it. That does get better with time as the skin heals, and keeping the topical treatment in the refrigerator, and this applies to all topical treatments, keeping it in the refrigerator can actually help reduce that. There is a black box warning for rare cases of malignancy. This is a theoretical based on transplant patients and animal studies with very high doses. And it's unclear if we see anything in topical use. And this is something that the black box warning is on the box. Again, if you don't talk to families and patients about it beforehand, they will go home and see that and they will not use it. So it's important to let them know that this typically this is in response to the oral medication. There have been numerous safety studies that shows that this is a safe agent to use, and we do not see increased rates, but that black box warning exists because there still needs to be more data here to tell us for sure that the topicals don't play a role, but it's really not something we worry about. So looking at some efficacy, I wanted to make sure for the lesser known agents beyond topical steroids, I do cover some efficacy data in a little bit more detail. So this first one on the left was looking at tacrolimus. Now this is a pretty old study, but this looked at the body surface area involved after weeks of treatment. And early on in treatment, about 2 weeks after starting treatment, we see a reduction in about 10% body surface area for a lot of these patients, and up to 12 weeks even more. So you can see the clear difference here over placebo or vehicle. Keeping in mind that in a lot of these AD studies where they use different topical treatments, the patients in the placebo arm are using a non-medicated vehicle, like an ointment without medicine in it, which is also very moisturizing. So in a way, they're still doing some type of treatment because we know that topical moisturization alone can be therapeutic, and they're being monitored closely. They're expected to do this every single day, twice a day. So they might be even being more proactive about their care than they previously were. So a lot of topical AD studies, we do see substantial placebo effect because of that. So looking on the right side at pimecrolimus, looking at patients that were on pimecrolimus versus vehicle and either clear, almost clear, or having clear to mild disease, we see much higher rates of patients being clear or almost clear compared to vehicle. And then looking at body surface area affected as well, much improvement in body surface area involvement over time in patients that did topical pimecrolimus, but perhaps not as robust as tacrolimus, which reflects the ointment versus cream debate. We can use topical corticosteroids and TCIs in tandem together. One of the ways that we do this is we'll use the topical corticosteroid short term, this is what I like to do, to control the flare and reduce those immediate symptoms. They can use it twice a day, let's say for 5 or 7 days with good skincare, increasing the bathing, all of that. Then transition to the topical calcineurin inhibitor, using consistently for a couple weeks to kind of keep it under control and be steroid sparing once we gain that initial control. And then finally transitioning to that maintenance period. For topical corticosteroids, a lot of patients can get by using it once or twice a week for maintenance or prevention. For topical calcineurin inhibitors, we sometimes need to use 2 to 3 times per week. So every other day, every 2 days or something tends to work for a lot of patients. And after you go through this with patients, a lot of times they find what works for them. They know if they don't use their topical for 10 days, they will flare. So that's a great patient to maybe start the proactive once a week. And then that prevents that weekly, or I guess every 10-day flare-up that they typically experience. Next, we're moving on to another ointment, topical phosphodiesterase inhibitor. This targets PDE4, which is involved in decreasing cyclic AMP levels that are required for the production of pro-inflammatory cytokines within the skin and the epidermis. The one that we have available for this is called crisaborole. It's an ointment that's indicated for mild to moderate AD in patients aged 3 months and older. It can be applied twice daily to affected areas, and there's lots of good research on the safety and effectiveness, and especially mild AD and really little young kids that are really born with eczema. Unfortunately, I'm presenting this to be fair and balanced, but I just don't see a lot of effectiveness of this agent. And I think in my practice, because we are the specialists, we see patients that are beyond this level of severity. So that is very likely why I'm not seeing a lot of success with this agent. But in order to be fair and balanced, I wanted to include it. Studies indicate significant improvement over placebo, and like I said, mild to moderate AD. It's comparable efficacy to tacrolimus based on their research studies, and better than pimecrolimus. Again, that's where the ointment, this is another ointment, so the ointment cream debate comes in. Another steroid-sparing agent. So for the patient that has overall xerosis or for maintenance, I'll recommend this and that agent, this patient that maybe a parent really wants to avoid topical steroids. This is another option for them to consider. Many times they try it and they come back and tell us the eczema is uncontrolled, unfortunately, because we're just seeing a more severe phenotype of patients in my office as a specialist, and this likely applies to dermatologists as well. The most common side effect is application site pain, burning, stinging. Unfortunately, that happens a lot, and a lot of patients don't tolerate because of this. And we want to make sure we avoid in patients that are allergic to propylene glycol as a contact sensitizer, because that is included in this agent. Some examples of efficacy, again, keeping in mind that vehicle placebo effect here. Patients that achieved success, what they thought was an IGA score of 0 or 1. Now that means they are clear or almost clear. And I'll go through some of these grading scales and what they mean. So on the left here, we got this graph. patients in both their AD studies at day 29. So within a month of therapy, twice day application, we had more of a percentage of patients on crisaborole who had clear, almost clear skin with a significant noticeable improvement over placebo. And obviously a substantial vehicle effect here because the vehicle itself is a very good moisturizer. And then here are some photos on the right showing some examples of patients where this might be a good fit for them when they have really mild, maybe non-lesional AD, that they just need a little bit something more and perhaps they don't want to use topical steroids. This is a great option for them. Next, we're going to move on to the topical Janus kinase inhibitors or JAK inhibitors. JAK-STAT signaling is part of the immune pathways that are involved in AD in a lot of different diseases, like autoimmune diseases as well. The signaling is involved in Th2, Th1, Th17, Th22 responses. I'm not going to go through this whole slide, but it's a beautiful picture on the right here that us immunology people nerd out about. But ruxolitinib is the topical JAK that we have available. It's FDA approved for patients 12 and older. It targets JAK1 and JAK2, and again, it's in topical form. So it is approved for patients 12 and up for short-term and non-continuous use. So basically treating that flare-up, resolving the flare-up, and then using again over time with the next flare-up. It's also used in vitiligo. There is a black box warning on this label. We'll talk about when we get to the oral JAKs later, but a black box warning on the topical JAKs mainly is in reference to oral JAK inhibitors. So not really something we worry about, but again, something we talk about with our patients just so that they're aware of that and not surprised when they see that. We do see significant improvement in AD severity scores with ruxolitinib, and a lot of patients really like this. My challenge is because it's relatively new. It's only been on market, I think, for like 4 or 5 years, perhaps. I have a challenge obtaining it and getting payer coverage. But my patients that are able to get it, they love this stuff. It simplifies their treatment plans because this is safe to use on the face as well as other areas of the body. It's not a steroid. It works very well. And it's what we call cosmetically pleasing. It's a very easy to apply, non-sticky cream. So I'm a big fan of this when I can get it, and my patients love it. And some examples of some photos on the left here, patients with severe IgA scores. These are patients that have moderate to severe or moderate eczema, let's say, and then they start their topical JAK inhibitor. And after week 2, these are the effects that we see. So pretty profound improvements here. Looking at both of their research studies, TRUE AD 1 and 2, these are patients that have a treatment effect of their IgA scores, meaning a significant improvement where they went from moderate or mild severity to clear or almost clear. So compared to placebo, and they looked at 2 different doses or percentages of ruxolitinib, with the end all being the approval of 1.5% ruxolitinib. As you can see, there's a substantial improvement over placebo here, a much more obvious treatment effect in these studies. And these patients also in the TRUE AD study, pretty similar here in the second study that they did with similar patients as well. So really mild side effect profile. Again, there's a black box warning related to the oral JAKs, which we'll talk about in a little bit. We do see increased rates of things like folliculitis that we might think could be treatment emergent related events, but otherwise, a lot of these things listed here aren't really things that we think could be treatment related, but they did see in the research studies. So we'll change gears. That's pretty much all we have for topical treatments. We talked about the moisturizers, the topical steroids, and topical calcineurin inhibitors, as well as the other non-steroidal agents. Now we're going to talk about systemic therapy, and that's going to include our biologics and a little bit on the JAK inhibitors. In the allergy world, we don't use the JAK inhibitors as much because thankfully our patients really respond well to dupilumab or Dupixent. We use that a lot. We have many indications for that medication, and a lot of our patients, as we talked about earlier, have numerous allergic comorbidities and respond really, really well to that therapy. So when we're looking at systemic therapy in AD, we have all these targets that we saw on that schematic initially earlier in the lecture, but then now this is a new photo that has both our targets and the medications that are being studied or have been developed to treat AD. So in the barrier, we've got cytokines like TSLP, IL-22, IL-33. These all play a role in further barrier disruption, reduced filaggrin, tackling all of these inflammatory pathways, IL-4, IL-13, IL-31, which is a medication for chronic itch. all of these different immune targets exist, and there are therapies being developed or already having been developed to target these agents. Looking on a different way on the right side of the screen here, we've got the JAK-STAT pathway and where these systemic agents like dupilumab and tralokinumab work. Nemolizumab targets IL-31, which is responsible for chronic itch. This is a medication that is approved for use in canines and animals for severe atopic dermatitis and is coming soon to control itch in humans. Hopefully, we'll have probably a lot of patients that benefit from this. So I'm looking forward to using it when and if it finally gets approved. But then we have our JAK inhibitors. And these are the ones that are approved for AD are abrocitinib and upadacitinib. There are others that exist, but they don't yet have that AD indication. They're used for other conditions like psoriasis or psoriatic arthritis, for example. So we'll talk a little bit about these briefly, but we'll spend most of our time talking about the biologics because that's more likely what your AD patients, when they come to us and they're not controlled on topicals and with good skincare and trigger avoidance, they're most likely going to end up on the biologics. So our first one, the game changer, approved in 2017, we have dupilumab. This is a monoclonal antibody that targets the IL-4 receptor alpha subunit, which is the shared subunit between interleukin-4 and interleukin-13. These are cytokines or signaling molecules that play a huge role in this type of inflammation that we see in what we call Th2 diseases, diseases that allergy people treat, asthma, allergic diseases, eczema. So this medication works by blocking that receptor site. This is indicated for patients with moderate to severe AD, ages 6 months and older. So we do use it on little kids who have failed topical therapies. It's also indicated for use in moderate to severe or steroid-dependent asthma, nasal polyposis, eosinophilic esophagitis, and prurigo nodularis. So we've had this around for a long time. It first came to market under the AD indication, then all these other indications came through. It's soon to be approved for chronic urticaria as well. And we have a lot of success with this medication. So we're big believers in how well it works for our severe patients. So I wanted to include just a summary slide on the effectiveness here because there are so many AD studies for dupilumab that it's really hard to summarize them all. We need a whole hour and a half just to talk about them. So this is just a summary slide from Helio that I wanted to include looking at the efficacy across 3 separate studies looking at atopic dermatitis in moderate to severe patients. Okay, so to include a full kind of lecture on dupilumab would take its own hour, hour and a half. So I want to make sure I summarize some of the key findings from some of the major studies that have been done to get dupilumab approved for AD. So this is a compilation of that from Helio's website, looking at Solo 1, Solo 2, and Chronos studies. And I'll go through what some of these measures mean listed on this chart here. So IGA of 0 to 1, as a reminder, refers to patients that are clear or almost clear. What the EASI-50, EASI-75, and EASI-90 indicate, this is referring to the percentage of patients that have a 50% or more improvement. So that's what EASI-50 means. EASI-75 is the percentage of patients that had 75% more improvement in their skin severity. And then finally, EASI-90 are patients that had over a 90% improvement in their skin severity. And then they also looked at peak pruritus scores and whatnot. So in the first study, Solo 1, significant improvements over placebo. These were patients that were receiving the standard regular dose, 300 milligrams every 2 weeks. This is an injection, can be given in the office or at home if patients are comfortable, but significant improvements there. Solo 2, quite similar findings compared to placebo. And in these 2 studies, Solo 1 and 2, patients were not allowed to use their topical steroids, but in the real world, patients are because they've already been on them. They're still using their topical steroids. So when they looked at Chronos and looked at dupilumab's effect every 2 weeks with using topical steroids, there was significant more treatment effects with 40% of patients achieving 90% or more improvement, 69% of patients achieving that EASI-75. The EASI-75 is kind of really that cut point that a lot of us look at when we read about eczema treatments and articles and how effective they are. That EASI-75 has kind of been the bar and the standard. We want to see a high number there, and obviously that's pretty substantial there, with 80% of patients having 50% improvement. So huge, significant treatment effects with dupilumab. This looks at the further diving into the IGA score and that EASI-75, like I talked about, looking at patients in the Liberty AD Chrono study where they could use the topical steroids versus placebo. And there are some patients that got it weekly or every 2 weeks. And since they saw similar treatment results at every 2 week or every week dosing, they kept the dosing at every 2 weeks when it came to market. So as you can see, again, illustrating significant improvements in these patients. The initial dose really depends on the age. There's typically a loading dose followed by a every 2 week dosage. It comes in a pre-filled syringe or a pen device that's really easy to use. And patients tend to do really well with a self-injection, but for those patients that aren't comfortable doing it or don't have someone at home to help them, we do offer this in the office, but many patients do it at home and do great with it. The most common side effect by far are injection site reactions and then conjunctivitis, which we can see in a subset of our patients with AD. And this is because it tackles IL-13, which is also involved in tear production. So sometimes we can see increased dry eye with using Dupixent or dupilumab. And then there are some other ocular and other dermatologic significant adverse events, which really aren't necessarily treatment emergent, but there have been cases of serum sickness like allergic reactions, for example. So we want to make sure we're monitoring patients closely when they first start medications. But typically this is very well tolerated and it's approved in ages 6 months and up. We have a lot of little toddlers with severe AD that look like some of those pictures we saw earlier that are on this medication and doing quite well, and their families have a break and their quality of life is improving. So some examples of before and after, this is pulled from the dupilumab website, but also from Dr. Boguniewicz, who is a huge researcher in AD, from one of his recent articles in 2018, looking at the effectiveness where we have severe patients that have more widespread disease that get on dupilumab and do very well. And looking at the right here, obviously we see some very extreme examples of people with very severe infected, excoriated, lichenified skin, and they get on Dupixent, and after 16 weeks, their skin looks like that. And really, before we had dupilumab approved, I mean, these patients were desperate and they were living on oral corticosteroids or immune suppressant medications and just had a really awful quality of life. And so when this medication came to market, knowing that it's safe, does not suppress the immune system, and seeing the treatment effects, it really was a game changer. Lots of improvement in how frequently we see depression, anxiety in these patients, knowing that there's something more that we can do for their skin. So we're huge fans of it. We also have to talk about tralokinumab. This is another biologic. This targets IL-13 on its own, not that shared receptor subunit, so a slightly different mechanism of action. This is only approved in ages 12 and up. Theoretically, it does have pretty similar treatment effects to dupilumab, maybe a little bit less, of course, but we're typically using dupilumab over this because one, it's tried and true, right? We have a lot of great long-term data on it. It's approved in the younger age groups, but dupilumab also more effectively treats other conditions that a lot of these patients have, like asthma and sinus disease, let's say. So we don't really use tralokinumab very much, at least from the allergy setting, but it is effective as a possible treatment option for patients that have failed topical treatments or for whatever reason could not take Dupixent or dupilumab. Let's say they had allergic reaction. Let's say they can change to this agent. So pretty good treatment effects in the real world study that was done over on the right, all the way over here, extra 3, when patients were allowed to use their topical corticosteroid and tralokinumab, they had a pretty significant treatment response as well. Maybe not as robust as dupilumab, but that makes sense because the mechanism is a little bit different. It blocks a little bit less of that cascade than dupilumab does, but still worth mentioning. And this is another way to kind of look at that data from extra 1 and 2, looking at tralokinumab every 2 weeks. A lot of patients that take this can reduce to every 4 weeks and have really good results over placebo. So that initial dose is many more injections, 4 pre-filled and subcutaneous injections, followed by subcutaneous injections every 2 weeks, and you can decrease to every 4 weeks if you're doing well and skin is improving. And then similar side effect profile to dupilumab, really, really mild, well tolerated, with injection site reactions being the most common. Now a little bit on the oral JAK inhibitors. So the oral JAK inhibitors, I'm a big fan of. But thankfully, dupilumab often treats most of my patients, and we don't really have to use these. In the derm space, they use these a lot more. They're a lot more comfortable with using them for AD patients because they've had them around for a long time to treat other conditions that I don't treat in my clinic. So in the allergy setting, when we're seeing patients with other allergic comorbidities, we don't really rely on the oral JAKs as much as maybe our dermatology colleagues are. And that's why in the guidelines and the Quad AI and allergic kind of organization guidelines, these kind of fall after the systemic biologics, whereas our dermatology colleagues in the American Academy of Dermatology will kind of put them equal to the biologics. But for various reasons, we don't consider them quite there yet from our perspective. And it's mainly because of our comfortability using them. So these are oral medications in once daily or twice daily forms that are used for moderate to severe AD when other systemic therapies cannot be utilized. Typically, the only way we can get a patient on an oral JAK is if they tried and failed the other biologics I just mentioned. So the benefit with the oral JAKs over the subcutaneous injections is that we do see a quite rapid onset of action. It might take dupilumab a full 12 to 16 weeks for patients to really get that robust treatment response. But I've got patients that have been on oral JAKs and they get improvement within a week, and it's pretty robust. I like to utilize these agents off label as a bridge to help patients while they wait for dupilumab to kick in. They haven't been studied in that capacity, but we're pretty comfortable using them that way. But there is potential for long-term disease control in these patients with this oral medication if they're doing quite well and if they're tolerating it and laboratory values stay normal. So this does require some type of laboratory monitoring as well. So just very briefly wanted to touch on some of the efficacy endpoints here. And you'll see some of these, some of these scores are pretty incredible for some of these medications. So looking at the JADE Extend trial, this looked at abrocitinib. This took patients on 100 or 200. And again, looking at their EASI-75 scores, oops, let me go back. Their EASI-75 scores, 80% of patients responded and had 75% improvement or more of their skin, with almost 60% having that EASI-90 score, so 90% improvement. And then looking at upadacitinib compared with dupilumab, we see a lot more efficacy for upadacitinib, where we're potentially sacrificing some safety here. And we'll talk a little bit about that in a second. But again, patients that reach that EASI-75 score with upadacitinib, 71% versus dupilumab, 61%. So higher efficacy there. EASI-90, 61% versus like 39% for dupilumab, with better protection in itch scores as well with upadacitinib. So things I wanted to point out here. I'm not going to dive into much more detail here, but we'll talk about those kind of safety warnings here. So the most common side effects that we'll see is acne, nausea, nasopharyngitis, upper respiratory tract infections, but boxed warnings do exist. And the thing to be aware of with these box warnings is that they are based on very severe patients with rheumatological conditions like rheumatoid arthritis or psoriatic arthritis that are 50 and up and already have underlying cardiovascular risk factors. So we're already looking at a different patient that maybe is not our classic AD patient. And these potential warnings of serious infections and malignancies and severe cardiovascular events are really based on those patients. We cannot really extrapolate it to our typical young adult with AD who does not have any cardiovascular risk factors or other conditions that make them more at risk of these other possible severe side effects. So unfortunately, this safety warning leads to a lack of kind of overall adoption of using oral JAKs in the allergy space. We know they're effective. We see the science, but we're going to be going with our dupilumab that also treats those comorbid conditions as well, with this as a second option if they don't improve. Phototherapy, I have to touch on this because it's mentioned in the guidelines. Phototherapy is safe and effective, especially narrowband UV rays. It can be effective in both chronic disease control and acute flares. Unfortunately, we do see a lot of feasibility issues, and a lot of dermatologists do not offer this. There's limited access. And a lot of the studies on phototherapy show that you have to do it 2 to 3 times a week or more to have effect. And in the real world, these patients just can't make that work. They have jobs, they have other things to do. But we do know that it is an effective option. And I do see some patients doing phototherapy for their AD as a way to help improve the overall effectiveness of other treatment modalities that they are doing as well. So had to include it because it is in the guidelines as well. Other treatment options, and these are all things that we use before dupilumab, these would be systemic immune suppressants that are considered in severe refractory disease. I have not once written for one of these medications, besides the steroids at the bottom, which I'll talk about, since dupilumab's come to market for AD, thankfully. I use these for other conditions, but not atopic dermatitis any longer. So these all required lab monitoring routinely, and had some other gnarly side effects sometimes associated with them in addition to immune suppression. And then, of course, systemic corticosteroids. We really advise against the use of systemic corticosteroids. We don't use them often at all for AD. We see many of our colleagues in other specialties using them quite a bit. Unfortunately, we will see some improvement, but it can lead to long-term steroid withdrawal, which can then cause rebound AD and more severe uncontrolled disease than they initially had. So while it can be a quick fix for maybe some important special events that a patient might have coming up to help kind of get them through that, we rarely use we rarely use systemic corticosteroids. We more so are only using these when a patient might be approaching systemic therapy. So that's really the only time I've utilized them, is when I have a patient who is severe and is about to start dupilumab, for example. I'll put them maybe on a taper of topical or oral corticosteroids to help improve their control long term and kind of reset things while they're waiting to start dupilumab. Infections in AD are quite common. We talked about this a couple times. Viral or bacterial, a lot of these patients are staph carriers. And the reasons why they get a lot of infections is because of that impaired skin barrier, that impaired immune cell regulation, and they have that Staph aureus on their skin. And there is a potential for these patients, especially with really severe AD, to have potentially life-threatening septic type infections related to their skin. So it's important to take these very seriously. However, the use of antibiotics for atopic dermatitis flare-ups are controversial, and really should only be used in cases where other options have not been helpful. So it's really controversial if putting a patient on an oral antibiotic can make a difference. Topical antibiotics are preferred to spot treat any kind of lesion that maybe looks a little suspicious, crusting, oozing, kind of like an impetigo looking lesion. We can use mupirocin for that, but oral antibiotics, not really clear if they have a place in this area. Bleach baths is another way, also a little controversial, but studies show that it can increase severity substantially for moderate to severe AD, but really has no impact on milder atopic dermatitis. And it's really important, if you recommend bleach baths, that you're really cautious and careful about making sure families have written instructions on how dilute the bleach needs to be and how much bleach they can put in the tub according to the size. So this is still something that we practice today, but really, thankfully, don't have to use that much because we have a lot of newer therapies that help to improve disease control. But this can be helpful in those more severe patients. And different things that can relate to loss of disease control. So when we have a patient who was previously well controlled and then suddenly they're not controlled anymore, things you need to think about are new environmental allergens. Perhaps they went off to college and there's a lot of dust mite exposure, other things like that. We need to think about, did they develop allergic contact dermatitis to one of the agents that typically was safe for them or something that they're using for their AD? I don't recommend Aquaphor in any of my AD patients, the Aquaphor ointment, because lanolin, which is in Aquaphor, is a very common contact sensitizer. We see a lot of AD worsen because of Aquaphor, even though you would think it's a very good emollient. That's another example of a patient that would have loss of disease control. I'll ask them, what are you using? You know, if they're using something that's common to cause increased allergic contact dermatitis or increase severity, fragrances, whatnot, then we'll pull that off and make sure they switch to something else. Of course, poor adherence and then cost or lack of access to healthcare. Sometimes our patients are lost to follow-up, and of course they come in a year or two later and their eczema is severe again. So really, there are a lot of things that can play a role here when someone is suddenly controlled, outside of course, their condition just worsening on its own. And then finally, another talk on allergen immunotherapy and atopic dermatitis can be considered in patients, especially if they have other allergic comorbidities like uncontrolled sinus disease or allergic rhinosinusitis. They also could be helpful in patients with AD that are triggered by exposures to various allergens, like the classic patient that goes to a house that has numerous pets and they come home and for weeks their eczema is flared. That's another way that we can see AD be helpful. A pretty big systematic review looking at 23 randomized controlled trials, looking at both subcutaneous immunotherapy and SLIT, which is off-label in the United States, but used elsewhere in the UK and Europe, did demonstrate that there is improvement in 50% or more from baseline in patients that did allergen immunotherapy or allergy shots or drops compared to patients who did not. And this has been especially shown in some studies looking at house dust mite sensitization as well. So it is a good adjunctive therapy, but it's not usually something we're jumping to first unless patients also have other uncontrolled allergic conditions. So to review, we covered a lot. We're going to go back through this really briefly. Our basic management includes all AD severities and includes trigger avoidance, daily bathing or showers, liberal and frequent use of moisturizers and emollients. Those milder patients with intermittent exacerbations, we can use a low to medium potency topical corticosteroid for 7 days beyond clearance, make sure they're well controlled. And then also we can consider using other agents based on patient and family preference, like a topical calcineurin inhibitor or crisaborole. And mild to moderate with frequent exacerbations, that's when you really want to start thinking about proactive therapy with your patients, but we can have them on a maintenance topical corticosteroid or maintenance topical calcineurin inhibitor. We could also use other topical agents for these patients like ruxolitinib, the topical JAK. And then for those moderate to severe patients, those are the patients that really need to see the specialist, us or dermatology. And we think about biologics, phototherapy, the oral JAKs, and then if all else fails, we can think of those systemic immune modulators. But thankfully, because of the awesome new treatments we have available, we're able to avoid those agents. Reviewing it in a different format, that patient that has mild disease that is not controlled, when you're stepping up, you have the option to increase the topical corticosteroid potency, add a TCI instead, or add crisaborole. Then after a 4 to 8 week trial, if that patient still has severe uncontrolled AD, when they're more moderate to severe, that's when you want to refer to a specialist, and we'll consider phototherapy if we have the feasibility to do that, dupilumab or tralokinumab, which this article is from 2018 before tralokinumab was approved, so it's not on this list, but we'll consider those biologics or systemic immunosuppressant therapy or the oral JAK inhibitors in those patients. But really in the real world, we're looking at dupilumab first and then all the others afterwards if a patient doesn't respond well to dupilumab or they continue to have uncontrolled issues or they have side effects that are quite bothersome. So following kind of these treatment guidelines, they're well-established, well-studied guidelines for the American Academy of Dermatology and Academy of Allergy, really can give us this kind of stepwise treatment pattern of how to treat these patients, with also knowing when to appropriately refer these patients to a higher level of care. And finally, wrapping up with some resources, the National Eczema Association, I did refer to this numerous times throughout this conversation tonight, and then the Academy of Dermatology. We've got the Atopic Dermatitis Yardstick, which was published in 2018. I pulled a lot of material from for this talk. It's a little outdated. It doesn't include some of the newer stuff, but it's really, really good primer on atopic dermatitis. And then we've got the updated 2023 Atopic Dermatitis Guidelines as well. And then there are a lot of free CME on atopic dermatitis out there. So you can go to many of these CME organizers or websites and find access to free CME on atopic dermatitis to learn much more than what we were able to discuss tonight. So that's all I have. Thank you very much. And I appreciate you all for listening. Thank you.